And we call this epilepsy. Generally they'll diagnose it as epilepsy once a child's had at least 2 seizures. And many kids develop chronic seizure disorders where they just have recurrent unprovoked seizures. The cause can be idiopathic, meaning no real cause. They just were born with a genetic predisposition towards seizures. They have a lowered seizure threshold in the brain, or seizures can be acquired after some kind of a brain injury has happened. And we classify seizures by what we see, what the seizure looks like. Partial seizures have a local onset, and it's just a small location. This can be a twitching of one extremity, can be doing the tongue in and out, it can be something with the eyes, but it's a localized, isolated area. A tonic-clonic seizure, and the old term for that is grand mal. This is the whole body's involved, and you can see the pictures over there. There's a stretched out and then pulled in, and I mean they really look like they're thrashing, and they'll fall down, so we want to make sure they're down on the floor and safe, not where they're going to hit anything. Before grand mal seizures, usually people have an aura. They can tell that it's coming, and for some people it may be a taste or a sound or a feeling, but somehow they can tell it's coming. And then they have a post-ictal state. After the seizure, they're usually extremely tired. Absent seizures, in the past these have been called petit mal. Kids who have these often have lots. They can have more than 20 a day. And this is the sort of thing, and these are usually kids between 4 and 12 years of age. That's when it'll start. Teachers will say, he just stares off every now and then, or she'll be writing and she'll just stop and not respond when I talk to her, and then she kind of comes back and is fine but doesn't remember it. Those are absent seizures. Atonic or akinetic, these are called, the old name is drop attacks, and you know, A as in no, tone or movement. These kids just fall down to the floor. Usually starts between 2 and 5 years of age. Myoclonic seizures, this is sudden muscle contractures. And one way to tell a seizure from just other muscle movement, if you touch the extremity with the seizure, if it's just a little bit of a, you know, babies will do that clonus. If you touch them, it'll stop. With a seizure, if you touch it, you'll feel that rhythmic movement underneath and nothing stops it. Or on those myoclonic, I mean, there's nothing you can do to stretch that out. Don't try. Infantile spasms, this is seizures that start usually between 6 and 8 months of age. When we see infantile seizures, we're talking about decreased intelligence. These kids don't have a very good outcome. Febrile seizures are very common. Somewhere between 3 and 8% of children will have at least one febrile seizure. Most often age is between 6 months and 3 years, but they're very rare after 5 years old. Boys have them more than girls, and if a kid's had one, they have between a 30 and 40% chance of having another. We don't really know why. We know it goes with high temperatures, and it happens while the temperature's going up. So we used to think it had to do with the actual elevation of the temp, how fast it was going up, but it doesn't seem to. A higher temperature triggers them more than a lower temperature, but it's while it's going up, and really we don't know why. Usually they won't treat these with anti-seizure meds because they don't have any relationship to developing epilepsy later, or they're usually very short and they don't leave any neurologic damage. Some doctors will put them on anti-seizure medicine for a year because a third or so of them will have a second one. So it's kind of hard to say how they'll handle that. but antipyretics, we don't usually treat temperatures at a low level on kids. We let it get a little bit higher. 101.5 is kind of typical for where we start giving antipyretics. On these kids, we're probably going to want to give it at a lower temperature if they've had a febrile seizure in the past. But these are rare. I mean, they scare parents when they happen. They're usually short, and they're really not a concern for the child's future life. Seizure medications. All of our seizure medications have a lot of side effects, but not controlling a seizure will do brain damage. So we need to do something. Tegretol, Dilantin, Depakote or Depakine, Zorantin, these are all frequently used ones. To keep them from having seizures, we're giving these oral probably, or GT or something like that. Realize if for some reason we're giving it IV on Dilantin, which is phenytoin, it cannot be mixed with glucose. It precipitates into a solid rock. So if you are giving that one IV, you have to make sure it's only with saline. It can't go with anything else. Now, even with seizure medicines, we can only totally control seizures in half to 3/4 of kids. And you'll see they often use more than one medication to try and get a little better control, because we can't go that high without causing too many side effects. So seizures are really hard to control. And then status epilepticus. This is what happens when a kid has a seizure that's not stopping. And generally they say it takes about 20 minutes of that firing in the brain, where it fires and then it triggers itself to fire again. So you get this cycle where it's just continually triggering. If that's going on for about 20 minutes, we've done permanent brain damage. The problem is if it takes 5 minutes for the ambulance to come and another 5 or 10 minutes to get to the hospital, we don't want to wait 20 minutes before we start calling or treating a seizure. But generally, once we're in the hospital, they won't want us to do anything, depending on the child, for anywhere from 3 to 5 minutes before we treat it. And then when we do, the things we're going to treat that active seizure, so this is not just preventing, this is active seizures, are usually Valium, possibly phenobarbital, or Ativan, and that's the one I see the most in the hospital, is the Ativan. And we can give those pretty much any route. They can be sublingual, they can be IV. So what are our nursing implications during seizures? Well, first is to protect from injury. So depending on what kind of seizure they have, if they have those tonic-clonic seizures, we may have to put a mattress on the floor and a foam pad around the edges to keep them on that mattress if we're really worried about them falling out of bed. Or at the very least, we're going to protect the pad the side rails to protect them from banging against that. If they have the kinetic, where they fall to the floor and whack their head, we're probably going to have them wear some sort of a helmet to protect their brain during those. So we need to do whatever protection works for the type of seizure they have. We always want to observe and describe it, and we always want to time it. A 30-second seizure feels like 30 minutes while you're watching it, so use a clock to actually time it. We don't want to move or forcibly restrain during a tonic-clonic seizure. Now the exception to that is if they're in an unsafe position. If they're, we're sitting in a chair, we don't want them to fall off, so we're going to gently ease them to the floor, but we're not trying to stop the movements. We just want to put them in a position where they won't injure themselves. Never place anything between the teeth. We do want to protect the airway, and often when those muscles really clamp down, they can't breathe. Those respiratory muscles aren't able to move. So we often will blow by some oxygen, so when they do take a breath, we maximize the amount of oxygen they get, but we're not things are clamped down. We really can't force anything, force air in there until they take a breath. And then we want to try and see if we can find out what triggered it. For many people, things like flashing lights, or ringing bells, certain things will trigger it. So if we can identify the trigger, then we can help to prevent future seizures. Hydrocephalus. This is an imbalance of the production or the absorption of CSF fluid from the ventricular system, which produces dilation of the ventricles of the brain. So they're making more CSF fluid than either can move through the system or be absorbed back. And this is what we see. Hopefully we don't let kids get that bad here. You see that setting sun of their eyes too, which we talked about earlier. So pathophysiology. It can be excessive secretion of the CSF fluid by some sort of a tumor, or non-communication, so that CSF fluid, it's made in the ventricles of the brain and it's blocked there. It can't get out. It's supposed to communicate, move down around the brain, down the spine, and then be reabsorbed. And for some reason it's not doing that movement. Or we can have a problem with it not being reabsorbed. It's supposed to come back and be reabsorbed. And one of the common reasons for this is a myelomeningocele, or meningomyelocele. The book says it the opposite of the way I usually put it. And here's a picture of our brain. Here are the ventricles where that CSF is supposed to be made, and here they are very enlarged. And you can imagine this puts pressure on the brain. This happens usually in infancy, so the sutures aren't closed yet, so we get that very enlarged head. Here's another CAT scan showing enlarged ventricles. So what do we see in infancy? Enlarged head, bulging fontanelles. The skull bones will become thin with wide sutures and dilated scalp veins. We'll get bossing, which is that enlargement of the forehead. The setting sun eyes, where the sclera is visible above the iris. These kids will be irritable. They'll usually spasticity of the lower extremities, and if it's allowed to progress, brainstem dysfunction. So how's it managed? Well, remove the obstruction if there's something preventing the flow. And usually what we do is a VP shunt, ventricular peritoneal shunt. It has a one-way valve that has a set pressure, so as the ventricles develop to a certain pressure, then that fluid will flow out through the shunt and is just released into the peritoneal cavity where it's absorbed. These are put in with plenty of room for the kids to grow, and ideally they last their lifetime, but that usually doesn't happen. And the most common problem we see is a bacterial infection develops in there, and that'll usually plug up the shunt, and then it has to be replaced. 80% survival rate with shunts or with hydrocephalus because of the shunting. A third of them will be intellectually and neurologically normal, which means 2/3 aren't. Managing the shunt, we want to initially put them on the unoperated side. Don't lay them on top of that new shunt. If we reduce the ventricles too rapidly, that cerebral cortex is going to shift and move, and we risk tears and pulling away the dura from the skull, and we can cause a subdural hematoma. So they're going to want to let it reduce fairly slowly. Older shunts had an actual pump on it, where they had you push down on the pump on that one-way valve a certain number of times, every hour, every 2 hours. Now they're electronic, where they can come in and change the pressures every day. And some of you have seen the externalized shunts. They'll do that while there's an infection, and then they'll replace with an internal shunt. And here's a picture of how that shunt works.